Thank you, David. First of all, I'd like to thank Sachin and Parag for inviting me here. Today, I'm going to talk on the alignments technique proposed by John Insull 15 years ago while still relevant. This is my disclosure. We know there's a lot of options on this alignment, the coronal plane. You can have a mechanical alignment, kinematic alignment, that is restricted or inverse, anatomic, constitutional, and the latest is the functional alignment. Why there are so many alignments? Because you know that new technologies are precision-enabling devices, but we wrongly talk about accuracy. And what is your target? Coronal alignments, corrections, or static and dynamic, or soft tissue balance and extension or flexion? So why I use mechanical alignments? Because you know the purpose is to create an even load distributions on the new joint line. And it will end up in 5 to 7 degrees of valgus. It's the most widely used TKR for its high reproducibility and easiness. And if you look at the survival rate, it's still very high. So while some surgeons have advocated a paradigm shift in defining optimal coronal alignments and neutral alignments, classic bone cuts remains the gold standard. So, but some argue that the mechanical alignments consider only the 2 dimensions. So my good friend here, Stephen Howell, he said that when you use kinematic alignments, that you look at the 3-dimensional. But the concern is that the dangers of shifting the curve outside of the boundaries. And besides that, the concern of the patellar instability would persist after kinematic as abnormal anatomic parameters. And don't forget, currently kinematic alignments, TKA, performed with an implant designed for mechanical alignment. And besides that, in most of the Asia countries with a severe arthritis or severe pre-op metaphyseal deformity, sometimes it's very difficult to apply kinematic, and you might end up in catastrophic failure. So then they propose a restricted or inverse kinematic. The aim is to bring the outliers seen in the unrestricted within a safe range to avoid potential pitfalls. But at the end, if you look at the literature shows that there is no difference when you use the kinematic alignments or mechanical. Then Johan Bellemans come with a considerable various alignment who won the Chit-Renawat Award. He said that normal population has a natural alignments at the end of the growth by 3 degrees or various or more. So a restoration of the mechanical alignments to the neutral in these cases may not be desirable and would be unnatural for them. But still a question, do you dare to left the residual varus like this? Because Michael Minahin shows that the pre-op varus alignments corrected to the mechanical, the result will be the TSS score is higher. Then how about the analytic alignments? I said it's outdated because a lot of publications show it was not adopted widely. So I said the failed mechanical. So how about the popular now, the functional? Because it's enable quantifiable measurement and precision adjustment. The implant position based on individual patient's bony anatomy and soft tissue balance. This literature from our friend here, Sepp Lustig, shows that he said that a long-term follow-up remains crucial to assess both outcome and implant survival of this current concept. So then my question now, how does implant design matter? Because not all the TKA the same. So MRI studies on motions by Freeman and Pincus-Rofa shows that the plateau is asymmetric. So we have to relearn anatomy. And this publication from Philip van Overschelde shows that the current totally arthroplasty design, CR, PS, or mobile bearing do not provide a normal kinematic. And it is quite common when you flex it that you have a paradoxical anterior translations. So, and a flexus gap is not rectangular. So when you cut symmetric and balance a gap, you will end up entirely soft tissue, and the patient will perceive a pain, stiffness, and limited flexions. At the end, you got here, the publication shows mechanical alignments, which mean the pivot concept, significantly better forgotten joint score in CR patients. We did a study here on looking at the Asian and Caucasians and the mismatch, the wider with a higher MLAP ratios in the Asians and slightly various alignments. So Asian tibial tubercle end is more externally rotated. So be careful, the tibial tubercle is an unreliable landmark for Asian. Don't forget, Asian knee is not a small Caucasian's knee. And besides that, the Asian has a tibial anatomic axis does not pass the same point of the plateau as the Western Caucasian. So the question now, in this kind of patient, which alignment will you choose? Kinematic, functional, or mechanical alignments? If you look at the success rate, the publication shows that although 20% of patients who undergo knee replacement are dissatisfied in the short and midterm, but the impulse survival remains greater than 80% at 25 years. And according to Dan Barry, it's hard to improve 98% success rate, and you might have the chance of it becoming worse. So my conclusion, a surgeon must master the technique of ligament balancing and meso resection for the best possible result rather than blindly trusting a single method of alignments. Any technique done by a surgeon who truly understands the basic principle gives an excellent result, and the most sophisticated involves instrumentations in the hand of the cookbook surgeons can be a disaster. Thank you very much.